Hey, hi everyone. Getting a little head start to get so that we can get ahead. And I know like YouTube, they like throwing out those random like somebody has a new rap video or something they want to put on their YouTube ads, and it takes a while. Sometimes you can't skip them, so giving a little head start here. So it's not quite 1:30 yet. But if you're have your we're not using Top Hat today because we are like one lesson behind schedule. So I'm going to try to just go through as much of the joint anatomy as I can today. But yeah, just starting a little ahead of time to get things warmed up. But yeah, I hope you had a great weekend. Or did you feel the earthquake? Now, I mean, my building is a pretty skinny building, and we live on a kind of high floor, so we felt it. But my parents and my brother, in Makakilo, they didn't feel anything. Neither did my grandma, but maybe because like it's a big hill and it's maybe compared to a tall building, it's not as prone to shaking. But my yeah, was it my friend in Kaneohe said he felt it, but yeah. Yeah. Yeah, exciting stuff. At least it didn't knock out the power. Like some of you might have been too young to remember, but I think in 2006 there was like a really powerful one that like pretty much the whole state felt and knocked out the power. So thank goodness that didn't happen again this time. I know people are like there was an earthquake. Yeah, that was my other friends who lived like just a few blocks down. They're like we didn't feel anything. So yeah, but the people on the Big Island, the South Point, where that was crazy. Like things fell off of their shelf. Like, yeah, my friends on the Big Island, they said some things fell off the shelves, but luckily it was everything that could be replaced. But yeah, sometimes it's like, oh, did that happen? All right. So how are joints named? Now this is one of my favorite topics in all of anatomy because it makes sense. Like for joints, like here we have our shoulder joint, right? So what we have here, remember this fossa or cavity over here? What's the crow's name? That crow's name is the glenoid cavity, right? So Glen the crow sits on the acromion. This is the glenoid cavity or the fossa. Now, what do we call this bone here? We call it the humerus. So what's the anatomical term for the shoulder joint? It is the glenohumeral joint. And this is why sometimes you have to know not just the bone, but also certain markings because no, it's not called the scapulohumeral joint. It's called the glenohumeral joint. But this is why I love like how joint name or what we call joint naming or joint nomenclature is that it's very systematic. Now, gliding joints, so think about the joints in your body. They can be classified in different functions and shapes as well. And one of the functions, or actually more like the morphology, is a gliding joint. And what we have here is the sternum, right? So the sternum, and then we have the clavicle. And hey, we did cover this, and this is an important point of attachment because again, you have your axial skeleton over here, and you have the upper part of your that what you call the shoulder girdle or the pectoral girdle that connects your upper limbs to the axial skeleton. So this joint right here is the sternoclavicular joint. So that's why I love it. Like I wish everything in anatomy was this systematic and made sense, but joints are pretty easy because they tend to borrow names from the two parts that articulate. Now here's yet another joint. So here we have the humerus, and here we have the ulna right here. So what we have, humerus plus ulna is humeral or ulnar joint. And then do I have more examples? So the thing is that many joints have bones in their names. And again, when you have these two points articulating and touching together, they form a joint. So often these joints are named after the bones or markings that are the point of articulation between two bones. But again, this is why it's like you not only need to know all the bones in the body, but you should also know these specific, especially if a marking forms a joint with another marking or bone, then it's very important to know these as well. Now, okay, so in the previous slides I talked about there are different ways that joints move, and this is one way they're classified. So there are three main planes in our body, right? So we have our frontal plane, we have our sagittal plane, we have our transverse plane. So just like axes, or if you've taken any sort of like, hopefully you've taken some sort of basic algebra, but there's like, when you're taking those algebra, there's an x, y, and z axis. Well, same with the axis of motion. So we have monaxial, this is on one axis. If it's biaxial, it's along two axes. And triaxial is three axes. So again, mono means one, bi means two, tri means three. It's not like it, so like bicycle has two wheels, tricycle has three wheels. There's, well, sometimes you might see rarely uniaxial, but monaxial is what we'll use for this class. Okay, so yeah, so frontal like axes. So basically, how many planes does the joint move in? Does it move in one plane? Does it move two planes? Does it move in three planes? That's the difference between monaxial, biaxial, and triaxial. Now, monaxial movement, well, here we have the humeral ulnar joint, and the humerus is off to the side here. But think of it this way. Remember, mono means one, mono like monorail or monocle. So that's what we have here. So the humeral ulnar joint, it only really moves in one direction. So when you have your elbow joint moving, it's only going to go this way. Does it, if you freeze your upper arm, can you really move your this way, or actually like take the, I mean, you can cross your radius and ulna, but without moving supinating and prunating, can you actually like twist your arm this way all the way, like and spin it around? Not really, right? So this is why it's a monaxial movement. So yeah, that hinge movement. And in femur and tibia, can you take your leg, your upper leg and lower leg, and you can do this with your leg, right? You can flex and extend it, but can you move it this way by freezing the upper thigh, or could you move it that way? Or could you spin your lower leg around with relative to your upper thigh? You can't, right? So these are example monaxial movements. I should get like commission a drawing, because I can't really draw that well, but it would be very weird if like your legs could spin, or your lower leg could spin around, right, relative to your upper thigh. Okay, so biaxial movement, what are examples of that? Well, here we have a condyloid joint, and where do we find these? Between our metacarpals and our phalanges. So again, what should we call this joint? Metacarpal plus phalanges is metacarpal phalangeal. So maybe the only complicated part about naming joints is sometimes you might change a vowel, but again, it tells you exactly what bones that articulate and touch to form that joint. So why is it biaxial? Well, think of it this way, like this condyloid joint. Remember, our condyle means a knuckle, right? So these are literally our knuckles between our metacarpals and our phalanges. So can you move it this way? Yeah, you can move it in this axis. You can move it in this axis with your joint, with your fingers. But can you freeze your hand and rotate your finger along this axis? Not really, right? So this is why it's biaxial. I mean, if triaxial movement, your fingers would be able to spin around this way, but it doesn't happen that way. Or you can try, but don't try. I don't want any of you injuring yourself. But okay, so triaxial movement, what we have here is our glenohumeral joint, right? And also this is what we have down here in the hip joint. We have our the joint between our hip bone and our femur, right? So triaxial because you can move it in one plane, you can move it in another plane, and you can also rotate it this way, right? So this is why these are triaxial movements, and notice that they're kind of shaped like spheres, right? The head of the humerus and the head of the femur. So this is what helps contribute to this triaxial movement, an ability to rotate and move across multiple planes. And this joint right here is called the acetabulum plus femur, and this is the acetabulofemoral joint right there. You have clearly not seen The Conjuring. I have to see that one. I've never seen it, but yeah, I guess that's a good way of making a horror movie, is showing joints that move like the way they're not supposed to move. And assignments for this week. So there's a skeletal assignment coming up, and I think there might be one released on Top Hat. If not already, it's coming out pretty soon. Okay, so another thing is that not only do you classify joint movement by how many planes they can move in, but also their kind of general structure. So the types of synovial joints, I believe this is also in your upcoming homework. It can be, this is showing you how it would look like in a mechanical engineering perspective, but a lot of our joints in our body kind of work and can be classified into these 6 types of joints. So yeah, I won't go over all of these together. I mean, like, read this out to you, but I will try to go briefly over all 6 of these classifications. So what we have here are 6 types, and we actually covered some of these already. So like our intercarpal joints, these are actually the joints between, believe it or not, even though you have all those 8 bones in each hand, the joint, your carpal bones, they do touch each other and they form joints with each other. So when you're moving your wrist around, and some people, they actually can hear like little clicking noises. It might be due to maybe some of the movement of the bones or ligaments in there, but your wrist bones, they do form joints with each other and they glide against each other, and this is why you're able to form your hand and move your hand around and wrist. And the hinge joints, just like our classic elbow joint, our humeral-ulnar joint, pivot joint, so the atlantoaxial, so remember our C1 and C2 joint in our cervical 1 and cervical 2 vertebrae. So what we have is that atlas sitting on the axis and it spins around, right? So that's why you're able to move your head from left to right and rotate it left to right. Because if you didn't have that pivot joint, you couldn't pivot your head. Now, condylar joint, again, where's the example of that? Your knuckle right here. So the metacarpal phalangeal joints right here. These are example of condylar joints. Ball and socket, this includes your elbow joint, or not elbow joint, your shoulder joint and your hip joint, very different from your elbow joint. And then saddle, we have our metacarpal trapezial. So where do you find this metacarpal trapezial joint? Well, this is where you find it. So remember, metacarpals, these over here. Now, where do you find your trapezium? We know I have marked metacarpal here, but remember my mnemonic that your trapezium is on your thumb? So this is where you find the metacarpal trapezial joint. So this is why, so this is kind of interesting that it's like a biaxial joint, but it's not really shaped like that condylar joint. It's more shaped like a saddle. So notice the trapezium is like a saddle here. So this is why you're able to move your thumb like this, but also move it like this as well. So you have a biaxial movement, and yeah, so what do we call this joint? The metacarpal trapezial joint over here. So it's kind of like, I think just based on this morphology, and even though it's biaxial like a condylar joint, this is pretty much the only saddle joint you really find in the body, or true saddle joint. Now some other joints, they don't quite fit into categories. Like here we have our TMJ, or our temporal mandibular joint. And again, yet another example of this systematic naming. Your temporal bone plus your mandible makes the your TMJ. Now, we know that our jaw can open like a hinge, right? We can do that, right? But the cool thing about it is like it's more than a hinge. That's one of the primary functions, but it can also do this way. So your jaw can move this way, but your jaw can also protrude, retract, and also if you're looking at your mouth like this way, it can go side to side. So it's like sometimes we call it complex when it has a primary movement, but there's other movements that don't quite fit that primary movement. So actually, like your knee joint, is your knee joint a hinge joint? Mostly, but it does have some special movement to it that makes it a little more than just a classic hinge joint. But same with your jaw. Your TMJ, it works as a hinge, but also has other movements as well. Now, that's another thing too. So we have our ligaments. So our ligaments, these are dense connective tissue. So why do they have a lot of collagen? Remember, collagen is an important protein that is very important in terms of like tensile strength and holding things together. So they're like gram for gram stronger than steel cables. Now, these are like the steel cables that help to stabilize and keep your bones together in these joints. And remember, like, okay, so what's the difference between a ligament and tendon? All the way back to chapter 4. Remember that mnemonic, my favorite one. So ligaments connect bones to bones, and tendons. So when you have a T-bone, you have bone outlined in here roughly connected to muscle. So ligaments are what connects bones to bones, or sometimes like organs to to other structures. Tendons connect bone to muscle. Okay, so what we have here is the vertebral column and spinal column and all the vertebrae that are stacked up here. And what we see is a lot of these blue striped things. And this is implying all these ligaments and all the collagen fibers that run across these ligaments. So we actually have multiple layers, and yeah, I won't describe all of these right now because we're strapped on time. But you notice that there are many of these ligaments wrapped around your vertebral column. It's not just bones and these intervertebral discs. So this helps to form a lot of the strength of your spinal column, but also it kind of like, this is why like your shoulder joint is pretty flexible, but you notice that your vertebral joint, well, maybe unless you're one of those, like, if you ever watch like Cirque du Soleil and you have those like Chinese like contortionists and they can put their foot all like from the back posterior and put it over their head or stuff and put it in front of them. I mean, they have very flexible spinal columns and they probably stretch these and have a lot of flexibility in these ligaments. But most of us can't have that degree of flexibility. And why is that? Well, if you ever taken like something and wrapped around in saran wrap to reinforce it, it's kind of like that. The more you wrap around a joint with ligaments, the more stable it is, but at the same time it becomes less flexible. So this is why your spinal column is it's very stable and very strong, because you have all these ligaments that help to reinforce not only the entire length of the vertebral column, but also between the individual vertebrae as well. So yeah, you have all these ligaments that run outside, inside, between the spinous processes. You have all these ligaments running through alongside your spinal column. Now, this is an interesting one called the nuchal ligament. So the nuchal, or actually, if this is very interesting and useful root word because it refers to like the back or nape of the neck. And the nuchal ligament, what we have here is that this helps to counterbalance the weight of your skull. Because remember, your skull balances, that occipital bone balances on that atlas, right? And it's very easy for your skull to like tip over this way if you didn't have extra ligaments to support it. So the cool thing about this nuchal ligament, it runs from the external occipital protuberance. And if you feel the back of your head and feel the occipital bone, you might feel a little bump. That's a natural bump. So that's where this nuchal ligament is running to, and it runs down to this, what we call the vertebral prominence, that's C7. So that's going to run all along the cervical vertebrae, and this helps to form something that keeps your head from, or helps to support the weight of your skull, because again, you have all this bone right here, so it's very easy without this, it would be very easy for your skull to tip forward. Luckily, this ligament helps to hold your skull upright. I mean, you have muscles as well, but this is one of the many structures that help to counterbalance your skull. And if you're very lean, you might have, now this is where it's kind of hard to see I tried to use various mirrors and my phone and whatnot to see if I had one. So this is one you might, if you have a friend or a family member, they might tell you if you're very lean and don't have much like fat on your neck, you might be able to see your nuchal ligament through your, yeah, but actually it was really cool. I forgot his name, but student, like, I noticed that a lot of the classmates behind him were very, very excited. And we're like, what's that? And well, he didn't know that he actually had a nuchal ligament that's pretty visible. I mean, not so much in this, or you can kind of see it right here. So not as prominent as hers, but what we could see is like not only the spinous processes, but we could actually see a little ridge here because he was pretty lean. Well, yeah, if you're very thick like me, you probably can't see that as well. But yeah, you have that nuchal ligament that helps to support the weight of your skull. Now you also have these intervertebral joints, and why do you have all this support right here? Well, you have all these foramen as well, so why do you have this foramen? Well, the vertebral foramina is that you have the spinal cord running through that, and you also have these spinal nerves that run from the side and extend from the spinal cord between these intervertebral foramen to branch off to the rest of your body. Yeah, so this is why this intervertebral foramen is very interesting, because why? You can't see it with the individual vertebrae because you actually need two of these. So you actually need one vertebrae to form the superior part and another vertebrae to form the inferior part. And why do you need these little like side portholes? Well, again, just like I said a few moments ago, is that you have a spinal cord running through the vertebral foramina, but you have the spinal nerves that branch out through these intervertebral foramen. But hey, am I the only one touching the back of your neck? So the great thing is like, this is where especially for, I think Unit 2 is the easiest part of the semester, because you have a skeleton in your own body. Your own body is your own cheat sheet. So if you're doing like things like this during the exam, or feeling things like that, I mean, I'm actually support it, because it's like, okay, you're kind of saying, oh yeah, that's right, I'm palpating this. I know I have where my occipital protuberance is. I know where my ligaments are. So yeah, by all means, your body is legit as long as you don't write anything on it. Okay, so what we have here between the vertebrae, again, it's not going to just be bone on bone. Remember, your bones, they move all in the bones that form joints, they're going to move all the time. So you kind of want something to help prevent them from rubbing up against each other and wearing each other down. So between your vertebrae, you have something called intervertebral discs. And roughly the intervertebral discs are made out of cartilage and fibrous tissue, and also this other thing, another type of substance we call, okay, well actually let's rewind a bit. So the fibrous part is what we call the annulus fibrosus, and I put an extra N in parentheses here. I've seen multiple spellings of this. I've seen annulus with one N, I've seen an annulus with two N's. I accept both for this class, and someone asked something about like capitulum, but capitellum, spelled it that way. I looked it up, and it turns out like it both are accepted spellings, although capitulum with two U's tends to be used in humans, and the one with the E tends to be used in other organisms and animals. But for this class, I think, yeah, they kind of they refer to the same general structure in both. Yeah, so annulus fibrosus, one or two, I don't really care for this class because I've seen both used. But they both come from this root word meaning annular or ring-shaped. Now what we have here is a nucleus pulposus, and this is again, so we already have like three definitions of nucleus. We have the atomic nucleus, we have the cell nucleus, but now this is called the nucleus pulposus. But whenever you see the word nucleus, it refers to something central. So this is like a pulp in the center of an intervertebral disc. So yeah, it's annulus fibrosus. Yeah, here we have in the Martini textbook, they use a double N. In the OpenStax, they use one N. They both are fibrous, and they're both very strong because they have this this very strong fibrocartilage structure. So this is what you would see if you look at it from superior view, is that you have all these rings of fibrocartilage that surround a very soft nuclear pulposus. Okay, so I like to liken like this. So if you've ever gone to like Maui and had like one of the jelly donuts, and you have what do you have, the jelly, like that sweet jelly in the middle of the donut. So I like to think of the fibrocartilage and the annulus fibrosus, kind of like the dough that surrounds it, and that sweet jelly like that nucleus pulposus. Because the nucleus pulposus is, I heard I've actually never seen like how it looks like in real life, but supposedly the consistency is kind of like egg white, or something very gelatinous but very soft. Or if you're more local, what happens if you or this is like mochi ice cream. So I think of it like a harder, what if it's kind of stale? The inside kind of gets soft, the outside's kind of hard. So I like to think of it this way. You have a soft inside but a hard outside. So the nucleus pulposus is that soft inside. The annulus fibrosus is on surrounding it. Okay. All right, so the thing is that these intervertebral discs, say you're applying a lot of stress to your vertebral column or spinal column, these discs can actually be damaged. And oh yeah, Malsa with the custard filling. Yeah, now they have that at Leonard's, and I think Pipeline Bakery too. Okay, so what we have here is that sometimes, even though your spinal column can deal with a lot of stress, you can actually cause damage to these, and these discs can also experience stress as well. So here we have a bulging disc, and what happened that caused this bulge? Well, thing is that we call this, or you might have heard this term, especially if you you or someone you know has had like back problems, they might say, oh, I had a slipped disc. So this is what they're referring to. It's some sort of damage and trauma to their intervertebral discs. But it's not really slipped as in it's completely out of place, but rather it's herniated. So when you have a hernia of anything, it's something kind of busting through a layer of the body or of tissue. So here we actually have the nucleus pulposus bursting through and the annulus fibrosus, and that's what we see in this herniation. Like if you've heard of other hernia, like a muscular, like if you have an abdominal hernia, that might be your intestines poking through the abdominal wall. But in this case, with the intervertebral disc herniation, we have the nucleus pulposus pushing through this annulus fibrosus. But why do these slipped discs, or more specifically, herniated discs, result in pain? Well, here we have these nerves, and the spinal nerves, again, they're running between the vertebrae of our spinal column. Well, if this nucleus pulposus is under a lot of pressure and it bursts through this annulus fibrosus, this is going to apply pressure to the spinal nerve. And when you have compression of nerves, this is a common cause of pain, nerve pain. So here we have this spinal nerve being compressed, so this is going to send not only pain, but also nerves also are involved in sensing things as well. So sometimes you might get pain, or you might get this numbness or tingling or some sort of altered sensation from the areas affected by that spinal nerve. Yeah, so this is why this herniation, what the doctor will tell you to do, or the orthopedist will just say like, okay, they'll try to prescribe things that help to relieve the pain, but also relieve the stress on this area so this part can repair itself. Okay, so that's what happens. So again, the annulus fibrosus, it surrounds this nuclear pulposus, and what happens in a herniated disc, it's kind of like when you take a jelly donut or a filled one of the maltazes with fillings and squish it too hard. What happens? All that soft jelly-like stuff flops out. So that's kind of like what happens with this herniated disc, is that you're pushing all this like pressure on and stress on your spinal column, causing damage to the disc, and then the pulp bulges out, causing that damage. Or I like to think of it as this way. So here we have like a little custard-filled bun, and what happens during herniation? You squeeze you apply all this pressure, and it's pushing this nuclear pulposus outside. How do surgeries stop a herniated disc? Ooh, that would be really great, but yeah, I mean, I think we don't have time for that. I'm not sure if that would be considered a closed-ended question, though. Maybe if you rework it, you might be able to spin that into the top hat question. Okay, so let's see. Now let's talk about the shoulder joint. Very important joint, because why? Well, we use our arms every day to do our daily functions. So if your shoulder joint is acting up, it's really going to affect your daily life. So again, shoulder joint, very versatile because it has the greatest range of motion, but at the same time, it's the least stable. So remember those ligaments, especially like in the spinal column that you saw all those layers of ligaments? Well, the shoulder does have ligaments, but they don't wrap around each other like the spinal column does. So basically, the more ligaments you have and the more area they cover, the more stable the joint, but that makes it less flexible. If a joint is very flexible, it might have fewer ligaments, thereby making it less stable. So what we have with the shoulder joint is like not so much wrapping it over with ligaments. I mean, there are ligaments, but not nearly as much as the other joints. And then what we also have is not just like the ligaments and what the structures that support it, but also the shape of the joint. So that ball, just like a ball is you're able to roll around a ball on a surface. Same with the head of the humerus. It's able to roll around inside that glenohumeral or the glenoid fossa or glenoid cavity, depending on who you talk to. Okay, so what we have here, hey, remember, what's the point of our shoulder? What type of bird sits on the shoulder? It's the crow, right? It's the acromion, our point of our shoulder. And then we have our glenoid cavity or glenoid fossa. And then we have a coracoid process. And why do I emphasize all of those processes and landmarks? Well, the shoulder ligaments, again, we do have some that stabilize the scapula and the clavicle, but what we have here is the acromion And the clavicle, so what should we call that ligament? We should call it the acromioclavicular ligament. And here we have the coracoid process. What should we call the ligament that spans that and the clavicle? Maybe we should call it the coracoclavicular ligaments. And then we have our acromion and coracoid process. Let's call it the acromial. And then we have our glenoid cavity, and there's actually a ligament that's not shown in this image that spans it. And what we have here is the glenohumeral ligament. So you do have ligaments, but again, notice that they're relatively thinner, and even though they help to stabilize the joint, it's that trade-off. Are you going to have thicker and broader ligaments, or are you going to have more flexibility? So in terms of the shoulder joint, the shoulder joint is more on the side of flexibility. Oh, and there's also another ligament. So coracoid and humerus is the coracohumeral joint, or not coracohumeral ligament. So you have multiple ligaments, and this is the thing, like if the joint is, and the ligaments itself are, let me rewind. If the joint itself is relatively flexible but weak, how can we reinforce the strength of that joint? And this is where we have to talk about the rotator cuff muscles. So again, we did cover it in the previous lecture. We have the supraspinatus, infraspinatus, teres minor, again, not major, minor, and the subscapularis. But notice that these muscles, this is why, notice where they wrap around. All the tendons of these muscles, you not only have the ligaments, but the tendons also surround that joint as well. So that's why if someone has a shoulder injury where they strain the ligaments or tendons, often what you do is a lot of rotator cuff exercises to strengthen the muscles and tendons of the shoulder so that you're able to support the shoulder joint even more. But that's for, especially if you're going to physical therapy or kinesiology or orthopedics, very important to know your rotator cuff muscles. So again, to review our rotator cuff muscles, 3 of them are named after fossae of the scapula, but it's the lateral border that is the exception. So the teres minor, you have 4 rotator cuff muscles in each shoulder joint, and these are the 4. Alright, so the glenoid labrum. So what we have is actually within that glenoid fossa or glenoid cavity is a ring of cartilage. And what this is like this fibrocartilage lining, and it's actually a ring of fibrocartilage that sits within that glenoid fossa. And what it does is okay, not only it goes you have the glenoid fossa and it's a smooth surface, but this glenoid labrum is forming or have you ever seen maybe a extra when you have a rubber seal on something, if you're taking something apart and you see a rubber seal, it's kind of like that. And this is where you find that glenoid labrum. So it would be fibrocartilage ring, and it helps to line and deepen the socket of the glenoid cavity. So it's actually very important. You might think, it's just a ring, but it's a very important ring. You can live with trauma to it, but it's very important in overall stability of the joint. So what typically happens look at this baseball pitcher. I mean, I don't think I could extend my arm that way, but notice that what often happens in baseball and what type of injury? Well, especially with this pitchers, look at not only do they have to have a lot of flexibility, but they also have to whip this shoulder joint at high velocities and forces. So this is why there's a lot of stress on the shoulder joints of baseball players. So what type of shoulder injury usually ends a pitcher's career, even with the best in orthopedics? Well, there's something called a slap tear. And what does this, well, it's a tear, but where does it affect it specifically? So what it's called, slap is an acronym, superior labral tear from anterior to posterior. So what happens in a slap tear? So here's a healthy labrum, but with a slap tear, what we see is that, again, superior labral tear from anterior to posterior. So this is actually going to destabilize the joint, because now instead of having this nice socket that your humeral head fits into, now you have less stability because now this labrum has been compromised and it's no longer fitting as snug as well as it was when it was healthy. And I mean, I have to read the latest journals to see if they made any advances, but this is why it typically ends a pitcher's career, because they can undergo rehab and they can try to repair this, but will it heal back to how it originally was? And I think that's where, if there are advances in helping heal to 100%, this is why their pitching velocity often it never reaches the levels they were before the tear, because of this destabilization of the shoulder joint just due to the labral tear. Now what we have here is okay, now going from proximal, more distal, so the elbow joint. So many things support the elbow joint, many muscles and ligaments as well, and I'll go over a select few. So here we have the right elbow joint, and what we have here is like collateral ligaments. So collateral, whenever you hear that word collateral, remember lateral meaning to the side, and co, so co, when you cooperate, you work with someone, right? Or if you cohabitate, you live with someone. So collateral means together, but on the sides. So we have a radial collateral ligament toward, again, the radius is toward the lateral side, and then we have ulnar collateral ligament toward the midline. So they have stability on both sides of your shoulder or your elbow joint. But you also have these annular ligaments. So remember, annulus refers to something that's spring-shaped, just like our annulus fibrosus, right? So what we notice is that annular ligament wraps around the head of the radius. And what shape is the radial head? It's a round shape, right? So it kind of makes sense to have a ring around a round shaped radial head, so that's able to rotate. So this is why you're able to supinate and pronate and move your forearm like that, is because this allows your radius to pivot. So this allows your radius and ulna to cross and uncross. Okay, and what we have here, so remember our capitulum and trochlea are the condyles of the humerus, but outer to the condyles we have the epicondyles. So this is a lateral epicondyle, and at the elbow joint, well, what we call tennis elbow due to repeated movements of the elbow joint. So we also call it, I mean, it's commonly called tennis elbow, but the more anatomical term for it is lateral epicondylitis. So itis referring to inflammation. And where do we have this inflammation? It's along this lateral epicondyle. So again, whenever you have these projections, or not whenever, but remember that projections, they either fit into something or they're points of attachments for something. So in terms of that lateral epicondyle, it's the point of attachment for many of these tendons. So if you have continual movement and stress to these tendons that support the elbow joint at the lateral epicondyle, these can become inflamed, and this is why we have that pain when we get lateral epicondylitis. Okay, so moving down to the other girdle in our body, so our pelvic girdle, and we're going to talk about the hip joint. So also called the coxal joint, just like our hip bone is called the coxal bone. And what it is a very strong ball and socket diarthrosis. So it's a synovial joint, and synovial joints, I think it might be covered in your lecture. I mean, not lecture, but homework. So that part, if we have time, we'll cover it next lecture. But that's something you should definitely look up. Now, the hip joint has a wide range of motion, and why is it? Because like the shoulder joint, it's another ball and socket joint. And just like the shoulder joint has all these ligaments, so do you have a lot of ligaments in the hip joint. So you have these ligaments here, so the iliofemoral, pubofemoral, and ischiofemoral. Hey, ilium, pubis, and ischium, right? And femur. So that's again, this is why I wish ligaments, everything in anatomy was as logical as joints, because joint naming and the ligament naming in the joints, super systematic. So yeah, that's what we have here. The pubofemoral ligament goes from the pubis to the femur, and then with the iliofemoral ligament, it goes from the ilium to the femur. And if we go toward the back, we see our ischiotuberosity in the posterior. What should we call the ligament between the ischium and the femur? We should call it the ischiofemoral ligament. Now, what we have here are a lot of ligaments that wrap around the head of the femur and connect it to the coxal bone, right? But the thing is that also you have things in the inside of it. So what we have in the inside, if you cut away all those ischio, ilio, and pubofemoral ligaments, is that you have yet another some articular cartilage. You have hyaline cartilage right here, but you also have another labrum as well. So what we have here is, and the interesting thing about acetabulum is not just a bony socket. I mean, the bone helps to form the initial cup, but you also have this hyaline cartilage that helps to form a gliding surface of the femoral head. But you also have this transverse acetabular ligament. So this ring of cartilage is not completely 360 across the holes. You have this transverse acetabular ligament that helps to span these ends right here. So again, notice this cartilage isn't all the way there. But you also have a cut ligament right here. So the interesting that ligamentum teres is cut in this picture, but it would actually be attached to the head of the femur. So this is something you don't see in the images in the book. But the other thing about the acetabulum, just like you have your glenoid labrum, you also have the acetabular labrum. So just like the glenoid labrum helps to deepen the socket of the shoulder joint, the acetabular labrum also helps to deepen the socket of the hip joint and also stabilize it as well. There's many examples of of sports that use, like if you're a runner, if you're anything that involves your lower body, if you have a labral tear in that, that's going to affect your overall stability of your hip joint. Like, was it? Do I have time for story time? I remember I know I'm dating myself, but back in the early 90s, there was a figure skater called Michelle Kwan, and she was the GOAT then. She was the Simone Biles of her time. And I think what happened often during that time is these figure skaters, they would get really good, and then when they get this labral tear, just like the slap tear in baseball players, they would never land the same jumps and have difficulty as they went. She was the GOAT because I think almost every competition she either won or medaled, so that's why Americans were super hyped on figure skating. Or also, if you've also seen that movie I, Tonya, it was Scandal, it was the time to watch that because everyone was involved with the drama. This was before YouTube. But back to Michelle Kwan, once she got the labral tear, just like the baseball players who get the slap tear, she never reached that level again. So this is why, even though it's just a ring of cartilage, it might seem like a ring of cartilage, it's very important for the overall structure of these ball and socket joints. Okay, so then we have the knee joint, and the knee joint is a modified hinge joint. So it kind of works like the elbow joint, but there are special things to it. So the thing is that the knee joint, unlike your elbow joint, is supposed to support the weight of your body. Because when you're standing upright, I mean, maybe if you're one of those really great b-boys or dancers, you can walk on your hands and support weight with your elbow joint, but your knee joint, that's the one most of us use to support our weight. So what we have here is that the knee has many articulations, but what we have is with the femur and tibia. So notice that the fibula does not articulate with the femur. So unlike the humeral ulnar joint where we have both the radius and the humor ulna articulating with the humerus, we don't have that with the tibial femoral joint. So what we have is that the articulation between the femur and tibia, notice that the condyles are balanced on the tibia, both of them are, unlike the radius and ulna in the elbow. And you also have the patella, but it's not in this image right here because this image is trying to show you all the ligaments of the knee joint. Now what we have between the femur and tibia is something we don't quite see in the elbow. We have something called menisci, and what these are fibrocartilage. So again, that fibrocartilage, the more collagen rich, that instead of having a lot of ground substance, they have more of the collagen fibers. So they're C-shaped rings, or not rings because they're C-shaped, but they're C-shaped crescents of fibrocartilage, and they help to form these little pads. So they're not only there to cushion, but they're kind of like shock absorbers between the femur and the tibia. So this is where you find these menisci, and they are named, remember the fibula is lateral, so the lateral meniscus is on the lateral side toward the away from the midline, and the medial meniscus is the one that's in each knee located closer to your midline. And the whole purpose, shock absorption and to reduce the wear between the femur and the tibia. And also support too, so thing is, like, without this menisci, the thing is, if this is a femur and this femur here and this is tibia, these menisci also prevent this kind of rocking as well, so they kind of give lateral support. And there are many ligaments that support the knee, and the 7 main ones, so we have our patellar ligament, or again, depending, some anatomists, they get the patellar tendon. Patellar ligament, tendon, same thing, like, just know that it's there to help anchor and stabilize the patella and also the knee joint as well. There are popliteal ligaments, which are in the back, and in the Martini version of the book, it looks like one ligament, but it's actually like 2 ligaments that are crisscrossed against each other. So it's like the back of the knee. So you have like 2 layers that kind of crisscross in the back. And then you have your anterior and posterior cruciate ligaments, and they are inside of the knee joint. So you can't really see that just from the front or the back. You would actually have to dissect some tissue to see these. And then you have your tibial and fibular collateral ligaments. So remember, lateral meaning toward the side, and this co meaning together. So you actually have 2 ligaments that help to on the sides of the knee joint that help to stabilize. And yeah, so we have our patellar tendon or patellar ligament, same thing. Fibular and tibial collateral ligaments. And then what we have here in the back, the popliteal ligaments, they form this kind of crisscross right here. So there are 2 ligaments. And for our ACL and PCL, our anterior cruciate and posterior cruciate ligament. So the anterior one is, again, we're looking at the anterior of the knee joint here. So the ACL is going toward the anterior, and the PCL is going toward the posterior. So again, notice that it's going from here inside of the joint and extending toward the posterior. So this is why the knee joint is mostly a hinge joint, but the cool thing is that when you're locking your knees and standing up, there's actually a little rotation that helps to lock your knees in place. So when it's not just a hinge joint, but as it also does the hinge motion, it also locks to keep it. So this is why you're able to kind of like, it also helps in the stability when you're standing up and placing a lot of weight on this knee joint here. Yeah, so here we see the ACL. We're looking at the back of the knee now, so you notice that the PCL starts out inside the joint capsule of the knee, but extends toward the posterior of the knee. So if you've had any sort of knee injury or play sports where knee injuries are common, you might have heard of ACL or PCL tears. So what we have here is that we have a force, and say someone is, like, say this person is playing football or soccer, and then someone rams into them from the side. Well, things that these ligaments, like especially the 8 inner ones, they're meant to kind of provide rotational stability. But what happens if you apply force in the direction that's like perpendicular or not oriented along the direction that they're supposed to be stressed? So remember that these dense regular connective tissues, they're strong in the direction that they run. But if you're trying to stress them in the direction that they're not supposed to turn, then they're more prone to tear. So this is why we often see ACL and PCL tears when you start to move these or stress these beyond their limits. Like, another common thing is, like, what do some soccer players do? They have the cleats, right? And then when they plant their foot and then they twist it, what can they do to the ACL and PCL? Well, they're called cruciate ligaments because they form like a cross. They kind of crisscross each other. So if you're twisting that and stretching it, it's kind of like when you break the seal on a twist cap bottle. It's like if you keep on torquing it and twisting it, you can also pop these ligaments. But again, you have all these things that help to stabilize the knee joint. So yep, this is why ACL tears are so common. I used to have another slide. Maybe it's not showing up, but let's see. Maybe I can see if I have it in a previous version. But yeah, that's another thing. Or I thought, oh, I did have a question. Okay, so who is more prone to ACL injuries? So no need to open Top Hat. Let's just do it in the chat today. So females or males? Same sport, but who's more prone to it? Actually, I can put I can put a quick poll. Or, I can put a quick poll. Oh, so cool. Alright, so the answer is females tend to be more prone to ACL injuries. And why is that? Well, it's very interesting. There are many things that are involved in making someone more vulnerable to ACL injuries. One of the classic ones is like which way your tibia and, or not tibia, your femur is balanced and oriented to the tibia. So what we have here is someone who's bow-legged genovarum. But people who are knock-kneed, so not just females, but even if there's a male who's like bow-legged versus knock-kneed, people who have a more inward angle of their knee joints, they tend to be more prone to ACL injuries. So there are many things that are involved in ACL injuries, but what they think with the angle is what they call a Q angle. So this angle between here is thought to be involved and kind of increase or decrease one's risk of an ACL just by the angle and the way that force is transferred from the upper body or after upper thigh and everything stacked above it to that knee joint as well. Okay, so this is why females tend to be knock-kneed more. I mean, if there's a woman who's bow-legged compared to a woman who's knock-kneed, she has less chance of a ACL injury on average. But yeah, this is one of the major reasons they think. But there's also more reasons as well, but this is like, we tend to see more knock-knee morphologies in women. Alright, and that's it for today. I'm going to end it here. And when our study guides release, 1 week before the exam. So that's when we'll have a study guide. But again, study guides are pretty much outlines of what we covered so far. So what will we cover for Unit 2? Pretty much everything leading up to the nervous system. So we don't cover the nervous system until Unit 3. So pretty much skeleton or bone tissue, skeleton, joints, muscle tissue, and muscles. Does it also have to do with hormones? Actually, that's a good question. Like if hormone imbalances could cause an increase in or increase someone's risk of ACL injuries, that sounds like a good fact question. Alright, so I'll see everyone on Wednesday, and good luck and take care and stay healthy until then, alright?